Good evening, everyone. My name is Debbie Hilbasell, and tonight we're going to be doing case list reviews. I know that you guys have been doing these so far already, but let's just briefly go over again how you participate. When you look at your computer screen, there's a little orange arrow up in the top right-hand corner. Basically, what that does is it opens and closes your panel, just in case it's in the way of your case list when I pull it up. With regards to how to participate, it's pretty straightforward. It looks like, looking at you guys, it looks like everybody's on speaker and mic. Nope, one person's on offline, but is on telephone. If you are going to use the telephone, if you click on use telephone, then you will get a phone number, an access code, and a PIN in order to be able to rejoin the conference. And then again, you don't ask questions, but if you want to volunteer to go, you just raise your hand. The only thing when I have you guys all muted, but when I call on you, every once in a while, you'll be muted on your end. So make sure that little circle with the microphone in it is unmuted on your end when I call on you. All right, so now we're going to look for volunteers, but before that, I've got to pull up the case list. So let me do this and pull up the case list, and we'll go from there. All right, so let me just take a quick look through everybody and see who is volunteering. All right, I'll start from the bottom first. I'll start with Tiffany. You there, Tiffany? Tiffany?
Hello. Hi.
So, hey, there you are. Sometimes there's like a delay, like I'll click on it and it will show that I'm still, well, doesn't matter. I have you now. How, how
Yeah,
are you?
good. How are you?
Good. Hey, when do you test, Tiffany?
In January.
In January. All right. So you've got so are you happy about that or not happy?
I am.
Okay. Just because some people are like, oh my gosh, I just want to get this done. But anyway, so let me go ahead and pull up your case list. Do you have a specific case that is troubling to you that you would like to go over, or a specific case list you want me just to ask you about?
Any is fine.
Hey, Tiffany, I lost you.
Any case list is good.
Okay. All right. So let me just take a look at office here.
Sure.
Are you a generalist?
Yeah.
Okay. Let's look at patient number 9.
Okay.
So you had a 65-year-old who came in. Okay, are you there?
Yes.
Okay, yeah, and we seem to be having a little bit of delays. But anyway, you have a 65-year-old G0P0 who came in for her well woman visit and also was noted to have osteoporosis. Did she have this prior to her office visit at age 65? It had been diagnosed previously?
Yes.
Okay. So when would you typically do a DEXA scan for an average risk person?
For an average risk person, you would start at the age of 65.
So why would you do one earlier than that?
For patients with higher risk factors for osteoporosis, such as thyroid disease or for example, a parent with a significant fracture, they would be certainly a candidate to start DEXA screening sooner.
Is there any other factors that increase your risk for osteoporosis besides early, like parent with a fracture. Tell me some of the other
Yeah.
risk factors for osteoporosis.
So other factors would be earlier age of menopause, and what else? Low, for example, Asian patients with a lower BMI are also at risk of osteoporosis. I
Are there
believe,
any, go ahead.
sorry, also chronic steroid use can increase your risk of osteoporosis as well.
I'm sorry, could you repeat that? You cut out.
Chronic steroid use.
Okay, chronic steroid use. All right. So if somebody has some of these risk factors, how do you know if if it's enough risk factors in order to do a DEXA scan before age 65?
You can use the FRAX calculator and see if they're at increased risk. And it'll take into account like their age, their BMI, whether or not they're a smoker, any chronic steroid use, and then kind of determine whether you need to do a DEXA scan based on that.
And so what score would you have to have in order to say you should be doing the DEXA scan before age 65?
To my recollection, there are two types of categories. One is the risk of major factors, and I believe for that it is, I want to say it's around 20% or more, and then, or I take that back. There's like major and minor risk factors, or major and minor risk for osteoporotic factors. And for one of them is like 3%, and I want to say the other one is a 20% risk. And then if you meet that threshold, then that's when you would have a higher concern.
Okay, so in this case, the patient was diagnosed, for some reason, somebody determined she was a candidate for an early DEXA scan. How do you actually make the diagnosis of osteoporosis?
Um, so you get a T-score when that comes back. And if it is minus 2.5 or higher, then the patient does qualify for osteoporosis. I believe if it's, sorry, this is something that I definitely need to go back and review, but if it's minus 1.5 to minus 2.5, I believe that's low bone density or low bone mass, and that's when you would certainly, recommend lifestyle modifications like increased calcium intake and vitamin D intake and weight-bearing exercises, but the patient doesn't have osteoporosis yet.
All right, so with patients who have osteopenia, which is what we used to call it, or low bone mass, are there any patients that you would put on pharmacotherapy for
Uh,
just low bone mass?
yes, I believe, again, you can potentially use that FACS score calculator. And if they are at higher risk, then you could potentially start them on treatment.
Okay. So if you had a patient that, let's say you did her DEXA scan, you determined her T-score was a minus 2.7 or whatever, and you determined she had osteoporosis and was a candidate for treatment, would you actually institute therapy?
I think I would do so and consult with an endocrinologist. However, first, if there was such a patient, we would typically start with bisphosphonates.
Okay, so what would be a contraindication to a bisphosphonate?
I believe there is concern for like osteonecrosis of the jaw, and they also, after taking the bisphosphonates, should not like lie down immediately because there is some GI concern associated with that as well.
You there?
Yes, I'm here.
Okay. Yeah, it's just weird. The audio kind of keeps going in and out a little bit. All right. So you talked about osteonecrosis of the jaw, some GI concerns. Patients can't lie down for a while. If you were going to start somebody on a bisphosphonate, are there any labs or anything that you would do prior to starting her on it?
Um, there are a set of labs, and I think you would, well, checking like a calcium, vitamin D level, making sure that the osteoporosis isn't due to other causes that can be addressed prior to trying to just throw a bisphosphonate at it.
Okay, so let's say you did start her on a bisphosphonate for her osteoporosis. When would you repeat a DEXA scan and why?
Um, I believe it's in about 2 years to see how, well, I think it's in about a year to see how she's responding to the treatment.
What if you repeated it in a year and her T-score was the same? What would you do?
That's a good question. I think there would be concern that maybe she's, I mean, the good news is that she's not getting worse, but there is certainly also the concern that she's not responding to treatment. And so at that point, after making sure that, you know, she's taking the medication as she should, I would probably also refer her to an endocrinologist to make sure that we're addressing everything we need to address.
So you would you change your medication or add in another medication?
Um, I know there are other medication options out there that certainly can be pursued, but off the top of my head, I can't recall.
Okay. All right. So I'm going to stop here. Yeah, that was a tough one, wasn't it? Because you guys don't deal with osteoporosis much. I mean, you guys are most of your patients are young. Your practice is OB heavy, and osteoporosis is just not something that comes up very much. So anyway, so take a deep breath and let me just kind of there's a couple of points here that almost everybody gets confused on. So I want to just kind of go over them. Okay, Tiffany, if that's is that okay
Yeah,
with you? Okay,
absolutely.
okay, perfect. All right, so one thing that we know is, and this kind of ties into your wellness visits, they're going to ask, when do you start doing mammograms? How often? When can you stop them? Stuff like that. Well, one of the things will be when would you routinely start doing DEXA scans? And you're right, at age 65. However, there are women who we would consider screening before age 65 based off of risk factors. And as you pointed out, like hyperthyroidism, early menopause, Asian, low BMI, parental history of a hip fracture, chronic steroid use, all of those things definitely increase the risk for osteoporosis. So if I could totally see them asking you what increases risk, other things, of course, would be smoking history, if they drink 3 or more alcoholic beverages per day, and also if they've got like autoimmune diseases for some reason. We think it's due to something called tumor necrosis factor, which is irrelevant. You don't need to know that. But autoimmune diseases, even rheumatoid arthritis, etc., can increase the risk for osteoporosis. Now, used to be we would kind of just eyeball it and go, okay, so she's skinny and she smokes and she's postmenopausal. Maybe I better do a DEXA scan earlier. But now we can use the facts to actually quantitate if this is somebody who would qualify for an earlier DEXA scan. And this is where I see the candidates always get goofed up on the use of the FRAX, because there's two different ways we can use it. One is to see if a patient qualifies for an earlier DEXA scan. So we don't even have a T-score, right? Because we're just checking to see if we should even do one before age 65. So we go to the FRAX calculator, we put in all the risk factors, and we hit calculate. If their 10-year fracture rate comes back greater than 8.4%, then that is somebody who should get an early DEXA scan. It used to be 9 point something, but they just recently changed it to 8.4%. Why would they pick that weird of a number? It's because 8.4% risk, 10-year risk of fracture is the risk of fracture of an average 65-year-old. So if we're going to do routine screening at age 65, if someone younger than 65 has enough risk factors that they have the same risk as a 65-year-old, then you would do it. Does that kind of make sense?
Yeah.
Okay, so that's one way we use the FRAX. The other way we use the FRAX is once we've already done a DEXA scan. We know if they have a T-score of minus 2.5 or worse, they have osteoporosis and should be on pharmacotherapy. We know if they've had a compression fracture, they should be on pharmacotherapy because they're telling us their bones, even if their T-score is not too bad, if they already have vertebral fractures, they have crummy quality bones, they need to be treated for osteoporosis. Then the other one is, but what about the people with bone mass? That's where you pull in the FRAX again. So if they have low bone mass, you plug in all their risk factors, and then you plug in the T-score of their hip. And that's where if you get a major osteoporotic fracture risk of 20% or greater, or hip fracture of 3% or greater, you would put those people on pharmacotherapy.
Gotcha.
So two indications for FRAX. One, to see who should get a DEXA before age 65, and that's if it calculates 8.4% or higher. The other use of the FRAX where you were talking about, that's if the patient has low bone mass and we need to see if we should put them on treatment or just do calcium, vitamin D, weight-bearing exercise, and repeat a DEXA in 2 years.
Okay.
Okay, good. All right, then when it comes to pharmacotherapy, bisphosphonates are considered first line. Oral bisphosphonates are considered first line over the IV bisphosphonates, but we still have to make sure the GI thing is the biggest issue, that the patients need to be able to take the tablet on an empty stomach with a full glass of water, stay upright for 30 to 60 minutes, and not have severe reflux, etc. And the reason is the bisphosphonates are very toxic or caustic to the esophageal mucosa. It can cause like esophagitis and ulcers and stuff like that. So we don't want it refluxing back up in their esophagus. That's why they have to stay upright. They also, the bisphosphonates are cleared through the kidney, so anyone with impaired renal function. So the two biggies with bisphosphonates would be renal function and GI reflux type stuff. The osteonecrosis of the jaw wouldn't be a contraindication. It's a very rare side effect, rarely ever seen with osteoporosis doses of bisphosphonates, really seen more when we're given the really high doses for metastatic bone disease. All right, labs that you should do before you would put anybody on a bisphosphonate. Part of it's to make sure they don't have contraindications like impaired renal function. But the other thing, as you appropriately said, is to look for secondary causes. We shouldn't assume that all osteoporosis is just due to being postmenopausal in female. So you're going to do a chem profile that's going to look at renal function as well as your serum calcium level. It can even check albumin looking for nutritional status, but really we're looking at calcium in the renal function. check a vitamin D level before you start them on a bisphosphonate. That's one of the most common causes of secondary osteoporosis is vitamin D deficiency. You should check a TSH. What if they're hyperthyroid? Then it's not, you can throw all the bisphosphonates in the world at them, but if they're hyperthyroid, it's not going to fix it. And there's some thought that we should do a 24-hour urine for calcium excretion as part of the initial workup. I'd say most people do the first 3 and would only add in the second one is if on DEXA scan, you still are having loss of bone. All right, so when are you going to repeat the DEXA scan? Even if you start them on therapy, you're really supposed to wait 2 years before you repeat. Although can be controversial, I would say you would repeat it in 2 years. If you recheck it and their bone density is the same, as long as it's the same, or as long as it's the same or increased, that is considered a success. If she had a significant loss of bone, I'm really glad you said you would just refer to the endocrinologist for further evaluation. I think that's a totally appropriate answer. I just don't want, if they said, well, what if she had loss of bone? I don't want you to say, well, I'll just put her on a different med or add in a different med, etc. You need to evaluate why is she not responding? Is she have a secondary cause? Is she not taking it right, etc.? All right.
Yep. Thank you so
Okay.
much.
Oh yeah, great. Thank you for that one. It's a tough one. It's a good one to remind everyone kind of how to go over that. Thanks, Tiffany. All right, let's do Linda. Hey, Linda, you there?
I am.
There you are. Good deal. All right. Do you have any particular case list or case you would like to do?
Nope. Throw whatever at me.
Just throw away. Okay, let's see here. Let's do a GYN one. Are you a generalist also?
I am.
Okay. Whoa, let's look at patient 17. So you had a 45-year-old G0, P0, abnormal bleeding, huge 28-week size leiomyomatous uterus. She'd already tried everything, right? Prior myomectomy, prior uterine artery embolization. You evaluated for any pathology, and guys were like, it's time to call it a day. Tell me, what type of an abdominal incision did you do on her?
For her, I did a vertical because her uterus was very close to the xiphoid. It was definitely above the umbilicus.
Okay. And then with regards to how did you counsel her about the pros and cons of ovarian conservation?
Sure. So generally before menopause, I do recommend that we do ovarian conservation because of the all-cause mortality benefit for that. Although the pro of removing the ovary would be a possible avoidance of or limiting the risk of ovarian cancer. But however, given her age at 45 and she is premenopausal, her all-cause mortality would be more than that reduction of ovarian cancer.
Okay, and so what else with regards to reduction of ovarian cancer? So one thing, if you took out her ovaries, you'd be reducing her risk of ovarian cancer. Tell me how else you counsel her. What else can you do besides removing her ovaries?
I guess I don't understand the question.
Okay. What in counseling her, if she was concerned and you talked to her about, well, if we take your ovaries out, it is going to, you're going to lose some health benefit of this, but we
Right.
are doing what to also reduce your risk of ovarian cancer?
Oh, right. We are also doing a bilateral self-injectomy, which also reduces the risk of ovarian cancer.
Do you have any idea about what that does reduce your risk of ovarian cancer? Just doing the self-injectomy?
Percent-wise, I believe I want to say 8%. That's a number that sticks out for whatever reason, but I have to say I'm not quite sure. But the thought is a lot of ovarian cancer starts off peritoneally within the fallopian tubes of the ovaries. So just by removing that does decrease your risk of ovarian cancer.
Okay, so with regards to, tell me about the adhesions. What do you think was the etiology of
Sure, she's had
that?
prior surgeries. Her myomectomy was also uh, was done abdominally. And that was her only surgery, but I believe that that was the cause of her adhesions.
With regards to lysis of adhesions, when, let's say you were lysing adhesions and you made a 1/2 centimeter enterotomy into the small bowel, tell me how you would handle that.
Sure. In my practice, I would consult a general surgeon. But if a general surgeon was not available, I would repair it in 2 layers. I would do it in a way where it wouldn't narrow the lumen, meaning I would close it so that the suture is thrown in a way that it's parallel to the axis, so that, for example, if she had a longitudinal enterotomy, then it would accordion down. But that's what I would do.
Okay, and so now let's talk about the post-op complications. So the good thing is you thought about it, you did a vertical incision because of how large it was. You talked to her about the pros and cons of ovarian conservation, talking about how really up to what age does the ovary still give us some health benefit?
After 65, it gives very little.
Correct, absolutely. All right, so good. So my understanding, what I've read is bilateral self-injectomy reduces the risk of ovarian cancer by about 60%. That's
60.
what I've read, 60. So, who knows that how would they even know? But that's just what some of the reading I've done. At least it gives us a ballpark. So anyway, so we talked about that. We talked about lysis of adhesions. Obviously the 2 times we're most likely to injure the bowel is entering the peritoneum and during lysis of adhesions. But anyway, so then tell me how she presented post-operatively. How did you make this diagnosis of abscess?
Sure. So on post-op day 7, she actually called the office and said she was having some fevers, but otherwise felt well. So I instructed my office to have her come in right away. When I examined her, she actually appeared quite benign, but she did have a fever in my office. So I was concerned that there might be an abscess or I don't know, or like a bowel perforation or something. But so I sent her to the ER so that we can further work it up, and I had them do a CT with oral and IV contrast, and that is how we identified the abscess.
Okay, and so then tell me what antibiotics you put her on, and with regards to interventional radiology, did you get an immediate consult? Did they do that immediately or after she'd been on antibiotics? Just tell me how
Sure.
that was handled.
Because it was a 6 centimeter abscess, I consulted IR right away, and in the ER, I started her on Zosyn.
Okay, how long was she hospitalized?
I believe she was there for 4 days.
Okay, what factors like increase the risk for pelvic abscesses after surgery?
What factors? So
Mm-hmm.
if, for example, if there was an enterotomy or if there was a break in this sterile technique, if her pre-op antibiotic was not given within the appropriate time frame of within 16 minutes before incision. Those are the things that I can think of.
Okay, good. The only other thing I guess I could think of would be like if they were diabetic or, something
Oh,
else
right,
that would just
right.
right, that would just predispose them to that. Good. So she obviously had already, yeah, I don't think I have any other questions with that. The big thing would be how she presented with the pelvic abscess, how it was initially, what order did you treat it and why, how she presented. What else? I mean, when she came in on day 7, she seemed pretty benign to you. What if you had done the CT scan and you didn't see an abscess? What else would you be thinking about on like post-op day 7?
Right. So going over all of the post-op etiologies, like for example, DVT, like a respiratory, although that's less common at this point. If she had any other infection, uh, like a complicated UTI, or um, or her wound was infected.
Yeah, I agree. So it could be any type of a surgical site incision, which could either be the vaginal cuff as well as the
Right.
abdominal incision, could be a DVT, could be, I guess the only other thing I would think about that far out, especially when you said she didn't even really look that sick, but she did have a fever, would be like septic pelvic thrombophlebitis.
Right. Right.
That'd be
That's true.
the only other thing that I could kind of think of. All right, great. Good job. That was a big uterus.
Yeah. I do have a question
Yeah.
about, because her uterus was so gigantic and, there were fibroids and it was getting it kind of into the retroperitoneal space. That's why I did the lysis
hmm
the ureteral lysis, but I
hmm
didn't do a cystoscopy. Do you think that's a problem?
Well, you know what? Here's what how would you answer that? Let me before I say it, ask it. If I ask you, so if this uterus was so large and you were concerned with that you did bilateral ureteral lysis, could you tell me why you didn't do a cystoscopy? How would you
Sure.
answer that?
So when I did her ureteral lysis, I felt uh, her ureters were actually very far away um, from my operative field, which is why I felt comfortable not doing a cystoscopy.
Perfect. And that's how I would answer it, Linda, is that by
Oh,
doing the ureteral lysis, looking, you followed it, you've identified where they were, that you felt they were nowhere near the operative field, and in your judgment, it wasn't worth putting the patient underneath an unnecessary procedure. Because we do
great.
know that when we do cystoscopies, we increase the risk of UTIs, we increase the risk of OR, or we increase OR time, we increase cost, which is the whole argument of should you do universal cystoscopies or shouldn't you do universal cystoscopies? So I think that would answer it appropriately.
Okay,
All right, good.
perfect.
Okay, good. Thanks, Linda. Hey, Asra. Asra. Let's see. I think you're still muted on. There you go.
Hello, can you hear me?
How are you? Yep, I sure can. Let me see if I can find your case list. Oh, right, there it is. Do you have a particular case list you'd like to do, or
Nope, anything that you would like to go with.
all right, let me just do this. I'm just writing your name down. Okay, good. So I guess we haven't done an OB, so let's take a quick look at that. Let me kind of flip toward the end because we always stop on the soon side.
Mhm.
So have you guys done, have you done a shoulder dystocia yet, Asra?
No, I haven't.
Okay, let's just take a look at this. So here's a patient 30. She's your 25-year-old G3P0. She's term. Couple of different things she has going on with her. Number one was her gestational diabetes 2, and you listed that very nicely. Could you tell me what pharmacotherapy, what agent she was on for her GDMA2?
She was actually on insulin.
Okay, and why do we prefer insulin over the oral agents?
I believe it's because of the risk of hypoglycemia in the patient as well as the fetus.
Any other reason?
I think the long-term effects of it have not been well studied.
Okay, in what? In who?
In the fetus.
Okay, all right. So then, with gestational diabetes, what do you worry about? What if somebody comes in, they develop gestational diabetes? How do you talk to the mom about the risks in pregnancy?
I believe they're actually at an increased risk for a number of things. So, increased risk of a large baby with a shoulder dystocia and other delivery complications, as well as a possibility of stillbirth, increased risk of maternal problems, such as increased risk of cesarean section, operative deliveries. Lacerations, and in terms of the fetal risk, I would say stillbirth is one, congenital or risk of let's say the risk of miscarriage early in pregnancy for fetus.
For
And,
gestational diabetes?
well, that's more, I guess, for pre-gestational diabetes.
What about you started to go down the path of congenital anomalies? Where do we see that increased with?
The risk of congenital anomalies start to increase more with pre-gestational diabetics and things
Right.
like, I would say, cardiac abnormalities are what come to mind.
Yeah, I'm just going to stop you there for a quick second. You're absolutely right. So just make sure the big difference between pre-gestational diabetes and gestational diabetes is the fetal anomalies, because with the gestational diabetes, by the time you start to see insulin resistance occurring, the period of organogenesis is done. Whereas with the pre-gestational diabetes, they have hyperglycemia during the period of organogenesis, and that's where you're seeing all the different neural tube defects, cardiac defects, all that. So anyway, just keep that clear.
Okay.
Gestational diabetes, everything else you said was perfect. The large babies, the stillbirths, the delivery complications, mom C-sections, and all that kind of stuff. All right, so good. What when you talked about the SSE, sterile speculum exam, I'm like, what is SSE for? I was looking at the herpes thing. Now I got you. All right. So now let's talk about, so you induced her, and then tell me what you did as soon as how do you recognize a shoulder dystocia?
So once you have delivery of the head of the fetus, you have, I guess you would call it the turtle sign,
Hmm.
where you have resistance with expulsion of the baby. So, or it takes kind of like the head moves, retracts a little bit back. And so that's really the biggest sign of an impending possible shoulder dystocia.
Okay, so as soon as you see that, what do you do?
Well, I first of all alert my nursing staff and whoever is in the room that I think that I may have a shoulder dystocia. And at that time, we call for more help in terms of nursing. And then I also instruct the patient to stop pushing. And subsequently after that, um, my first go-to maneuver is McRoberts and suprapubic pressure.
Okay, so obviously the baby delivered with just those, so that was a pretty easy or quickly relieved shoulder dystocia. What would you have done
Correct.
next had you not relieved it with those two maneuvers?
After that, I usually move on to trying to assess to deliver the posterior arm.
Okay, so and why do you say that with the question mark on the end?
Oh, I didn't mean to have a question mark, but that
I
is what
know,
I do.
I'm just giving you a hard time. I'm like, what? So then say, next I would do attempt delivery of the posterior arm. Okay, good. All
Okay.
right, so let's say you did that, you attempted that, you were not able to get the posterior arm delivered. What are you going to do now?
The next maneuvers I usually will go to is Wood's corkscrew maneuver, um, and if that's not successful, I would try to do um, Rubin's corkscrew. So Wood's is when you're moving, when you're trying to move the posterior shoulder, and I think Rubin's is when you're trying to move the anterior shoulder, and you can kind of go back and forth with the two maneuvers to see if you can dislodge the anterior shoulder.
At any point in time, would you do an episiotomy to assist you in the delivery of a shoulder dystocia?
The only time I'll do an episiotomy is if I feel that I need more room posteriorly um, to be able to insert my hand into the vagina. Otherwise, I don't believe that an episiotomy is going to help me with the shoulders.
Okay, so let's say then you are attempting the different rotational maneuvers and this baby's really just wedged. You are not making
Mhm.
any progress. Tell me what you're going to do next.
You can try to attempt the maneuvers again. And you can also, with the posterior shoulder, I can try to deliver the posterior shoulder um, with like a Foley catheter or something underneath. Try to like hook that underneath the posterior arm if I'm able to get to it, and see if that will help me facilitate.
Okay, so you know I'm going to keep going. So let's say you've tried
Yep.
all of that. Okay, so no, seriously, because you know shoulder dystocia and postpartum hemorrhage are two things that
Mhm.
I'd be stunned if they didn't come up in the OB thing. So all right, so now you've attempted every possible thing that you can think of there.
Mhm.
So now, so it's still just you and two nurses, well, three nurses in the room, the labor and delivery
Mhm.
room who should be taking down, keeping track of the time and taking down notes, and then the two
Mhm.
extra personnel who came in. So what are you going to do now?
So after that, I could attempt to fracture the clavicle, and if that is unsuccessful, then I could potentially consider a symphysiotomy. I have never done one of those. However, that would be the next thing that I could think about. And ultimately, if those are not successful, then Zalvinelli maneuver, which I have only read about, not actually done, would be replacement of the fetal head into the uterus, and in attempt to potentially do a hysterotomy to deliver the baby.
Okay. All right. So let's go. And so where's anesthesia?
Oh, anesthesia is alerted when I asked for more help initially.
Okay. Okay, good. So you do it pretty early on. Okay. So some
Yep.
of the candidates will attempt, they'll call in the extra nursing personnel. And if the baby doesn't deliver in the first couple of maneuvers, then they're saying, okay, is there another OB on the floor? Get anesthesia in here, etc. So let's go back to the fracturing of the clavicle. How do you fracture a
Okay.
clavicle?
So the way to fracture the clavicle is to pull towards you in the midline of the clavicle and not in towards the baby, because you may actually cause lung injury as well
So
as nerve injury.
what's the purpose of breaking a clavicle?
It is to decrease the diameter that needs to pass through the beneath the anterior shoulder, the anterior, the pubic bone.
Okay, so once you've fractured it, then you're just
Um,
gonna see if the baby
then
falls out.
nope, you would repeat all of your maneuvers again because you have now a different diameter.
Perfect. That's what you forgot to say last time. You just said,
Sorry.
and if I'm gonna break the clavicle and then I'll just cut her symphysis. I'm just giving you a hard time, okay?
Yeah.
This is supposed to be the part where we have fun. All right. So
Right.
anyway, yeah. So what you're going to do, you did great. I'm glad you even knew about that shoulder shrug maneuver, that thing where you can do the catheter. It kind of, some of the candidates may not have heard about this, but I think it actually kind of makes sense. Basically, do you want to explain it, Astro, exactly how you do it, or do you want me to? I'll do it either way. Where you put the
I can
catheter through
attempt
the
to.
axilla. Yeah, go ahead.
I can try to attempt. So basically, you can either pass a catheter or anything that's like IV tubing. I've heard before too. You can pass that underneath the basically the axilla, and try to again decrease the diameter a little bit of the shoulders by exactly what you said, the shrugging part of what the baby's going to be doing in that maneuver.
Yeah, and so the thought is, if you hook that catheter or IV tubing, whatever, you're making a sling underneath the posterior axilla. So if you try to picture the baby, the anterior shoulder stuck, you're making a sling through the posterior axilla, and then you're pulling that shoulder up toward the baby's ear. So now you're bringing it, I guess, like more cephalad to the baby. Then holding that there, you attempt to do a rotation. And by doing the rotation, then the hopes is that what was the posterior shoulder will now be in front of the pubic bone. It will have cleared it already. So that's my understanding of how you do it. You shrug it and then turn it. That's that. All right, going back to the breaking the clavicle, yep, you've now reduced the bisacromial diameter. So once you've done that, you go back and you repeat every single maneuver. McRoberts, suprapubic pressure, delivery posterior arm, etc.
Mm-hmm.
If the baby's still stuck after that, they actually recommend you fracture the other clavicle and then repeat
Yeah.
every single maneuver again. Of course, by now, anesthesia's there, you're getting extra OB help, etc. I would not bring up cutting the symphysotomy. I mean, I just wouldn't. I would say
Okay.
the next thing would be you're taking her back to the OR, and you have two options. One is to attempt a Zampanelli, which truthfully by then my brain would be so freaked out. I don't know if I could think of what's a reverse cardinal movements of labor and try to put a kid back up inside. But the other thing you can do is, and you should say the Zampanelli, I'm just being honest with you. I can't imagine trying to have to do that. But the other thing is you're going to have to do a hysterotomy anyway, right? If you push the baby back up in with the Zampanelli. Another thing you can do is do the hysterotomy, and you can actually attempt delivery of that anterior shoulder with direct pressure. You know, now you've opened it, you're taking your hand and you're just pushing it down underneath the pubic bone.
Okay.
So operatively, to me, that makes more sense even than the Zampanelli. But if that didn't work, then you already have everything open and you could do the Zampanelli.
Okay.
But I would recommend to all of you just practice so that you feel confident of walking through every single step that you would do for a shoulder dystocia. Because I'd say that in postpartum hemorrhage, be able to talk about everything you would do, the dosing you would give, tell them that they're going to say she's still bleeding, and walk it all the way down to doing a hysterectomy. If you practice saying it out loud a couple of times, it will happen easily. Okay, so this patient, her baby really wasn't that big, but it was a pretty easy shoulder dystocia remedy. How are you going to recommend she deliver in a subsequent pregnancy?
So subsequent pregnancy, you can offer the patient a cesarean section, given the history of a prior shoulder dystocia. And I think it would also depend on whether she was a gestational diabetic again in that pregnancy as well, because that increases your risk of shoulder dystocia.
Yeah, would you ever, what if she was like, wow, I really don't want a C-section. What factors would make you more comfortable maybe letting her attempt a vaginal delivery?
Probably the weight of the baby, or the estimated weight of the baby, although there is an margin of error plus or minus 20%. So you can't really go based off of that entirely, but if it was a lot estimated to be a lot bigger than what she's had before, I would probably counsel her on that strongly, against that strongly.
Yeah, I think that would be just say, you were even surprised that at this size infant, she had any degree of shoulder dystocia. In a subsequent pregnancy, if she had gestational diabetes again, which she's at high risk that she will have it again in a subsequent pregnancy, and more likely, since it'll be another baby, because they seem to get bigger with each gestation, that you'd be very concerned with regards to that, and that would be how you would counsel her. So good.
Right.
All right, great job.
Thank you.
All right, let's see if we can get one more in. Hey, Ashley. You there? Ashley, you're muted on your end. There you go.
Hello?
Hey, Ashley, I hear you now.
I don't know why.
How are
I
you?
suddenly lost my audio. Here, let me switch my.
I can hear you
All
just
right.
fine. I can hear you.
Hello?
Yeah, I can hear you.
I don't know why I can't hear anybody.
I can hear you. There's some.
Let me switch on over. No, it's not
Okay.
working.
Huh.
It's odd.
It is odd because I wish I could. I wish you could hear me telling you I can hear you.
Audio. Here we go. Okay.
All right.
Okay.
Yeah, yay. I was gonna say, because the whole time you were talking, it was like terrible because I'm like, but I can hear you. I know you can't hear me, but I can hear you.
I was like, I think she picked up. I think she picked me, but I can't tell, and now I can't hear.
Oh my God, you poor thing. All right. So do you have a particular case or case list you'd like to do?
No, I will let you choose.
All right, hey, we started with office, let's finish with office.
Okay.
All right, let's fix something here. Let's see here. Have you guys done like well woman visits in the caseless review?
If we have, it's been a really long time
All
since.
right, they're kind of a pain in the butt, but let's just kind of go over it just because to see what kind of questions they would ask. All right,
Okay.
so let's look at your patient number 2. 65-year-old G3P2's coming in for a well woman visit. So you did a history and physical, age appropriate screening, and you did cervical cancer screening normal. What's age appropriate screening for a 65-year-old?
So for a 65-year-old, I'm looking at a DEXA if she didn't already previously have risk factors and get one earlier. And even so, if she's, if it's time for her to be screened, I'm looking for a mammogram. And if she is in need of a colonoscopy or due for another one, I am looking at her pap smear. And of course, doing the things that we do for all of our patients, domestic violence screening, depression screening, the seat belts and exercise and all of that stuff, as well as finding out if she's sexually active and at risk for sexually transmitted infections. Perhaps she has a new partner or partners.
Okay, so with regards to mammograms, she's 65. Let's say she's at average risk. What if she asked you at what age can I stop getting mammograms? What are you going to tell her?
So I believe that there's so many different bodies that speak to breast health screening guidelines, but I believe that if she has had if she's at average risk and has no, abnormal findings on her mammograms, then we could start discontinuing them at about 75 to 80 years of
Okay,
age.
all right. What about the pap smear? She's 65. You did her pap smear screening is normal. What are you going to tell her about pap smears?
So I would tell her that if she has had no abnormal paps in the past and is 65 years old and has had appropriate screening over the past 15 years, she could discontinue her screening. I believe for this patient in particular, she had either like missed one or she was this was gonna be her last one as long as this one was normal, and that was the discussion that we had before taking her pap.
What's the current recommendations for colonoscopies? When do we start screening, and is there a time that we can discontinue it?
Yes, so colonoscopy screening, depending on the governing body, recommended age of 45 to 50, if no other risk factors. And those are done, typically if they're normal, they are done once every 10 years up into the age of 75.
Okay. What about vaccines? What would you be talking to a 65-year-old about vaccine-wise?
So vaccine-wise, she would need her pneumococcal vaccines. Hopefully she would have already gotten her shingles vaccine. Obviously, we're talking to everybody about their flu and their COVID vaccine. We would need to know if she had had a Tdap in the past 10 years, and if she had not, then she would be due for that. I think we would start there. I would have to.
Yeah, I think that's got it. What
Okay.
about labs? What would you talk to her about laboratory screening?
Yes.
This
So
is a tough one because a lot of these patients have primary care physicians. So, sometimes the candidates might put on the well woman visit, labs up to date by PCP or something like that. But if you were serving as her primary care physician, what would you want to make sure you had?
Sure. So if she'd been coming to me and hadn't had care for a while, I would probably want to do a CBC to make sure she's not anemic. I would want to do a CMP to look at her renal function and her liver function. I would also want to do a lipid panel and a TSH. And if any of those were abnormal, we would talk about making sure that she got hooked in very well with a primary care physician.
Okay, what would be age-appropriate counseling under the treatment?
What would be age appropriate? Okay. So talking about all of the screening guidelines that we talked about for mammograms, colonoscopy, DEXA, talking about calcium and vitamin D supplementation for her age range, talking about the vaccines as we had spoken, and kind of going back to the vitamin D and calcium, talking about careful footing, weight-bearing exercise, so osteoporosis prevention. And then also, usually around this group, I want to make sure that I look at their medications. I want to make sure that I know if this patient is on HRT or ERT, and seeing if she feels ready to get off of that at this point, or kind of doing an assessment.
All right, that brings up a good point. If somebody is 65 and is on HRT, say she started it at age 51 with severe vasomotor symptoms, what would you counsel her about being 65 and still on HRT?
Sure. So I would counsel her that the goal of HRT is to reduce symptoms. It's for the treatment of vasomotor symptoms, and the kind of rule of thumb used in treatment is the lowest dose for the shortest amount of time. So it has been a long amount of time. I would certainly want to know what dose she's on. Is she on oral? Is she on transdermal? How is she feeling about her symptoms? And would she be open to maybe stepping down her therapy today and eventually continuing to decrease that dose in the future?
And why would oral versus transdermal make a difference to you?
Oral has a slightly increased risk. So when we're talking about risks and why we have to spend so much time talking about this, it's her risk of VTE. So the risk of stroke with the oral formulations is higher than the transdermal because of the first pass effect.
Perfect. Okay, great. So you did a great job on the wellness. So the one thing I did want to go over, which you did a great job, was like with everybody, I'm going to go over domestic violence, depression, etc. So when I've read through some of the different ACOG, recommendations, it's like, oh my gosh, all the stuff we're supposed to do at a wellness exam, we should allot like 3 hours.
Right.
Anyway, part of the age-appropriate screening, this is what I tell the candidates to do. ACOG wants us at every year screen for intimate partner violence, just like you discussed, depression. But here's one thing, they actually want us at every annual exam to update family history looking for hereditary cancer syndromes.
Oh,
so
sure.
that's in one of those things there. Then we're supposed to, of course, screen for substance abuse, and then screened to that they're up to date on their vaccine. So I just kind of always remember those 5. I'm going to screen on everybody, no matter what their age is. And then, of course, the other things really are the age appropriate. And you were spot on perfect with regards to the DEXA scans, the mammograms. You're absolutely right. Some say you should stop at age 75. Other ones say, you know what, you just need to look at the patient's life expectancy. And if you have a really super healthy, fit 75-year-old and you anticipate they have greater than an 8 to 10 year life expectancy, then you should keep doing the mammograms. So basically, it's really a life expectancy analyzation, because if they're going to be dead in 8 to 10 years, there's no sense to keep doing screening mammograms. The colonoscopies, it used to be that 45 for African Americans. Now they're starting to push that they're seeing younger and younger people with, especially like rectal cancer, that, well, maybe we need to just start doing colon cancer screening on everybody at 45, and that seems to be the push now. And then you were perfect on the pap smears, and then you were perfect on all her vaccines. Oh, and then age-appropriate counseling, absolutely. You talked about everything that you're going to do. The only other thing is, I remember reading ACOG said this one time about, cardiovascular disease is what kills the majority of us. So we should use the opportunity, the wellness exam, as our opportunity to emphasize the importance of a heart healthy lifestyle. So just make sure you throw that in there too, that for everybody that you're talking about the importance of a heart healthy lifestyle with good diet, nutrition, weight, don't smoke and all that type of stuff.
Okay.
So, but perfect. You did perfect. But I could actually see them asking about a wellness just because there's so much screening stuff that you kind of have to know, etc. So, good. Any
Right.
questions for me, Ashley?
So, okay, so the breast cancer or the mammogram screening is it's 75, or I couldn't remember if it
Right.
was 75 or 80, but is it pretty much 75 across the board for those that are saying you can discontinue at a particular age?
The United States Preventative Services and Task Force said you should stop at 75. Okay.
Okay,
Then ACOG says there is no age you should stop it.
got it.
They say you should evaluate at age 75, do shared decision making, but what you're really doing is looking at life expectancy. And if you, like I said, if you have somebody who's really fit and you're like, oh, this lady's going to live into her 90s, then you
Yeah.
should keep doing screening mammograms, because if you find breast cancer, you're going to do something about it. Do you
Yeah.
see what I'm saying? It's really more the ones that you're like, oh, brother, even if we saw something abnormal on a mammogram, we're not going to do anything. This lady's longevity isn't that. Do you see what I'm saying? It's really
Absolutely. Yeah.
that's really and that's why it really is a individual thing. And same thing with regards to HRT. You were spot on. Now, the internal medicine organizations, like everybody needs to come off hormones at age 65, and ACOG says there is no age at which patients have to come off hormones. It should, every year we need to evaluate, review with the patient, why are you on it? What dose are you on? Transdermal is always going to be safer than oral because of the VTE thing. Are you willing to try to decrease the dose? Are you willing to come off it? Because the indication for HRT is the treatment of moderate to severe vasomotor symptoms. So that's exactly right. But ACOG says no, you do not take patients. Everybody has to come off at age 65. Perfect.
All right.
All right.
Thank you so much.
All right. All right, I'll be back with you guys Sunday. So we'll call it a night for tonight. All right, thanks everybody.